Good morning, good afternoon, morning. Yes. So I'm going to review protocols for HIV opt-out testing at Cook County Jail in Illinois, Chicago, Illinois. And first I'll review when the jail had only opt-in testing by itself, which ended in March 2011. Then I'll review the opt-out protocol, which also includes an opt-in element. Cook County Jail was actually the largest single facility jail in the U.S. until they recently instituted some policies promoting alternatives to incarceration. So now it's among the largest. It has about 85,000 admissions a year, a daily population of 9,000 detainees approximately. And sort of amazingly, as many employees as there are detainees, which suggests one of the problems with incarcerating large numbers of people. Although in a time of unemployment, actually, I'm not kidding. They're talking about closing a couple prisons in Illinois, and that just hasn't worked because they're mostly in rural areas or semi-rural areas, and the people in those areas just fight like hell to keep them open for their jobs. This is a jail. The tall building in the back houses courts and some other offices, but everything in the foreground is part of the jail. And health services at the jail are provided by Cermak Health Services, which is part of the county, and it actually seems more attached to the hospital system than to the sheriff. And this is a rendering. I don't actually have a photograph of it. When it was opt-in only, HIV testing took place in the divisions after intake, not during intake processing. And the rapid turnover of detainees means that many were not offered testing. So about half are gone from the jail within 14 days, and a substantial proportion are gone within 5 to 7 days. Because of funding cuts over the years, most testing was actually done by a variety of grants and providers in the jail. So in this protocol, typically grant staff went into the divisions and would inform detainees of the availability of testing. And nearly all that testing was used a rapid technology followed by a Western blot confirmation. And the results were provided by the health educators. Now the new protocol involves HIV testing combined with testing for other STIs. It began April 2011, and it began with women only because that was a smaller and therefore more manageable population to begin a new program with. Testing is offered during intake processing now, the opt-out testing. Detainees are told they will be tested unless they choose not to. So the consent process involves sort of information giving to a group of detainees, and then there's signs in the area that also tell detainees about the testing. And people that don't want to be tested are asked to sign a form declining testing. They do syphilis testing, so they draw a blood specimen for HIV and syphilis, and urine samples for chlamydia and gonorrhea testing. People do not have to get one set of tests to get the other set of tests. They can specify which tests they want and don't want. Specimens are batched at the end of a shift, which is late at night, and sent to the county hospital. Results are available the next morning through a system-wide electronic database. And again, opt-out testing is still offered in the, opt-in is offered later in the jail's divisions. So if someone's HIV positive, a health educator meets with that person in the Cermak Health Clinic. So the people are called down to the health clinic. They can be called down for the health clinic for a variety of reasons. It doesn't identify them as having any particular problem. And they do a rapid test to confirm and then provide results. But the hospital also does a Western blot confirmation. The health educator refers the person to the jail's HIV clinic and to medical case management. The average time from intake at the jail, that's being brought into the jail, to the clinic is 3 to 5 days. And for those who are going to be released, a discharge planner makes an appointment for follow-up care. It was called the Core Center. It's a very large unit attached to Stroger Hospital that provides multiple services, case management, medical care, mental health, housing. There's a lot of programs, but it's all directed for people who are HIV positive. So in the 12 months, we have 12 months of data on opt-out. So in the 12 months before opt-out, there were slightly over 9,600 women who went through the jail, were admitted to the jail. And approximately 15 to 30% were tested. And I say approximate because that's our best guess. So we start drilling down into the data, and it was very hard to put all these multiple testing programs together. It's not a turf issue, although it is data are siloed, as others have pointed out in their programs. It's really more an issue of a complex organization operating in a difficult environment. With opt-out, the data collection is a lot more streamlined now. There are about the same number of detainees, just shy of 9,600, and 61% were tested compared to 15 to 30% in the opt-in protocol. Of that 61%, of the total, 48% were tested through opt-out and 13% through opt-in. With opt-out, there were 80 confirmed HIV positive. The new diagnoses, there were 13. And for previously diagnosed, but people who did not disclose that they were HIV positive when they came into the jail, there were 12 cases. For opt-in, there was 3 confirmed positives, 2 new diagnoses, and 1 who did not disclose coming in. So for opt-out, the new diagnoses is within the range. A recent paper reporting the results of opt-out testing by Beckwith and colleagues in 3 large East Coast jails. It's within the same range as those jails, at the lower end, but at the same range. And I think one of the important parts of this is not just the new diagnoses, but also the opportunity to re-engage people to engage people who have never been in care or who are no longer adherent. In a HRSA-funded evaluation that we did with women at the jail, of those who were HIV positive, over 80% reported having ever been on ART. And this is like the poorest measure of, the most severe measure of adherence. Never having taken one of your medications in the 7 days before being arrested, it was over 40% of the women who had ever been on ART were not adherent at that severe measure in the week before they came into the jail. So this is a real opportunity for both new diagnoses and to re-engage people. Challenges in implementing opt-out were usual program implementation issues for large organizations, such as getting interdepartmental buy-ins, adequate and appropriate staffing during times of budget cuts, and assuring consistency in explanations of the program and in the application of its protocol were problems. And this is partly driven by budget cuts. The county's looking to save money. They've closed some of clinics around Chicago. And that resulted in some nurses being transferred into the jail. And intake processing at the jail is probably the environment I least like to be in. It's just not a nice place to work. It takes a special folks and experience and who have a heart for the job. And some of the people that bumped into the jail there were really not a good match for the job that was required there. So they've worked to address that. Then, of course, venous access poses problems for compared to oral rapid testing for drawing blood specimens. So in summary, opt-out testing yielded the largest number of women ever screened in 12 months at the jail. And full implementation of the program is likely to produce the largest number of newly diagnosed in the shortest period of time, and the largest number of previously diagnosed but undisclosed cases in the shortest period of time at the jail. Some of the questions we're examining is why did 39% decline HIV testing when offered, even under opt-out conditions? And the other side of the question is why did the 61% accept? We'll be looking at whether higher risk people are declining testing. That includes in the notion of higher risk, not only people who are report individual level risk factors, but also people who come from communities with high levels of HIV prevalence where even modest risk behaviors are risky. And we'll be looking at just the packaging of the STI with HIV testing and what sort of impact that has on uptake. We'll be addressing those issues using survey and qualitative methods, and that will involve both detainees in jail and detainees after they're released, and the staff that are involved in testing. And finally, I'd just like to acknowledge NIDA for funding this and the data analysts at the jail who have a rough job.